Okay, looks like most people are getting settled into the room, and we welcome you to today's talk. Um, we're now kicking off this virtual talk series as a way to get the healthcare information you need today, since we're not able to come to you in your communities like we used to. Some housekeeping details. At the bottom of your screen, you'll see the Q&A button. This is how you'll ask questions of our panelists today. You can also submit them anonymously when you go into the Q&A button. The physicians will take your questions at the end of their talk after their presentations. Also let you know that this talk will be recorded. It will be posted on our website within a few days. Everyone that is registered for the talk will receive an email with the link to the recording to watch again and or share with friends and family. And the physician's contact information will also be available in that email, as well as at the end of this talk, if you care to reach out to them. I'd like to first introduce Dr. Aaron Loeb. He is a graduate of University of Wisconsin-Madison. He went to med school at Wright State University Boonshoff School of Medicine and did an internship and residency at Wayne State University School of Medicine. Dr. Loeb is fellowship trained in sexual medicine from the University of South Florida College of Medicine. Our other physician panelist today is Nanan Thermavalaban. He is a graduate of Boston University College of Arts and Science and med school at Boston University, as well as his internship and residency. He is also fellowship trained in male reproductive medicine and microsurgery at Baylor College of Medicine. Dr. Loeb, Dr. Thermavalaban, I'll hand it off to you. Thank you and welcome.
Great. Thank you, Mark. And thank you to the whole University Hospitals marketing team for helping put this together. Thanks to Dr. Thermavalaban for inviting me to come participate in this. And I think this will be a really good forum. Hopefully it's interactive. Please ask questions. We find that that tends to be the most informative part of the lecture. And I appreciate everyone for logging on this nice evening here in the early summer. But we'll get started. We got a lot of information to get through. So, you know, we chose two big topics that we see in a lot of our patients. Both Dr. Thermavalaban and I kind of specialize in male sexual dysfunction. And so we see a lot of guys who have questions about erectile dysfunction or, you know, what is low testosterone or do I have low testosterone? So we're going to talk about some of the diagnosis, some of the management options, some of the myths, some of the, you know, things you may read about, hear about in you know, the newspaper, and with erectile dysfunction, you know, why you're having issues with ED, what may be some associated things that may be going on, and talk about some treatment options. Because for both of these issues, there's very good treatment options that are available to you. You know, maybe it's just not knowing about it. So, you know, I'm going to kind of talk about the erectile dysfunction, and then I'll pass it off, and Dr. T is going to talk about low testosterone. But so what is erectile dysfunction? So, you know, it's simply just the inability to obtain or maintain an erection to your satisfaction. So it may just be, you know, it's not as hard as it used to be, or it doesn't, you know, I can't last through penetration or to orgasm. But if you're, you know, affected by it or you're distressed by it, you know, that classifies as erectile dysfunction. You know, you're not alone with this. We see guys all day, every day with this issue, and it ranges from guys in, you know, their 20s up to, you know, 90s. So you're not alone. This graphic says 50% of men. I think it's probably even higher if guys were honest with themselves and their doctors, you know, of having true erectile dysfunction. You know, what are some of the causes of erectile dysfunction? So I tell guys all the time, you know, aging does not cause ED, but it's all the things that go along with it. So it may be some medical conditions, diabetes, hypertension. You know, it could be those medical conditions, but it could also be the medications you're on to treat those issues. You know, obesity, inactivity, you know, hyperlipidemia or high cholesterol. And then we'll talk more about low testosterone, but that could play a role as well. You know, it could also be related to, you know, some surgeries you've had. If you had prostate cancer and you had a radical prostatectomy, or you had part of your colon removed for something, those issues can lead to erectile dysfunction. Smoking, you know, smoking's bad for every aspect of your body. You know, it affects blood vessels everywhere. So smoking can definitely play a role in erectile dysfunction. And then, you know, the stress, anxiety, psychological issues, depression, you know, all that stuff can cause ED. It can be associated with ED. And then it can be kind of this spiral where things, you know, it's continued, you know, to kind of downward, you know, go from there. I tell guys all the time, it's very hard to get a good erection when you're thinking about your own penis, and it creates this cycle. So, you know, trying to get off that, think about some options, learn of good options, can kind of help break that cycle. You know, there's some things that are associated with erectile dysfunction. As much as we care as sexual medicine providers that we want to improve your erections, improve, you know, your intimacy, you know, ED could just be a warning sign of something bigger that's going on. You know, the arteries that supply the penis for the erection are smaller than the ones that go to your heart or up to your brain. And so sometimes this is kind of the early warning sign of something bigger happening. So, you know, you may have been avoiding going to the doctor, and now you're having some erectile dysfunction, and you come in to see us. You know, we may send you off to a cardiologist or your primary care doctor, because, you know, you're not going to be worried about your erections if you have a massive heart attack or a stroke. You know, there's other things that are associated with ED, depression, anxiety, you know, marital stress. I mean, there's a lot of good data out there that shows that, you know, erectile dysfunction doesn't just affect things in the bedroom. It extends out in terms of relationships and, you know, self-esteem, things like that. So it's not, you know, I don't want anyone to just kind of blow it off and say, oh, it's not a big deal. You know, I'm, you know, this old, it's not a big deal in my life anymore. No, I mean, if you want it to be just in terms of the intimacy, we can help, but also this may be a warning sign of other things going on. So what are some of the treatment options? So, you know, at the top, lifestyle changes, you know, so anything that's good for your heart, good for your body is also good for your erection. So quitting smoking, like I mentioned before, exercise, weight loss, you know, medical management of some of the other comorbidities, you know, the obesity, the diabetes, all that stuff can help with erections. You know, going beyond that and, you know, continuing those things, you know, we may still need to do more things. You know, we'll talk some about kind of the FDA approved medications. So the pills, the Viagra, Cialis, you guys have probably all heard about those. Some advanced things that you may not have, there's injections, there's suppositories. I won't talk a whole lot about vacuum erection devices, but you may have seen these or heard about these. This is kind of a negative pressure pump. And then we'll talk about penile implant surgery. Let's see here. So I think I had a slide, but I don't think not sure if it made it on here, but I do want to mention some of the non-FDA approved treatment options that are out there that guys ask about, because you're reading the newspaper, you're listening to sports radio, the ads are everywhere for these health clinics and shockwave therapy. So kind of the stance currently in our medical societies and things like that is that there may be a role for some of this shockwave therapy, but outside of a clinical trial, we really recommend against going to these places and paying the $4,000 or $5,000 for really unproven treatment. And the results that are being published, you know, they're not scientifically based. So there is just a word of caution for some of those shockwave and men's health clinics. You know, the Priapus shot or plasma, things like that. You know, there may be some role, but just be cautious. And we'd much rather you guys come talk to us. And, you know, we can really have a greater discussion if you'd like. But let's talk about some of the FDA approved stuff. So the oral medication. So Viagra, Cialis, Levitra, you know, these medications just work to increase blood flow to the penis. They're not going to give you an erection. You still need stimulation. You still need a lot of your own input. You know, recommended take about 30 to 60 minutes before intercourse. For each one, there's kind of a slight variance. You know, with the Viagra or the sildenafil, it's best on an empty stomach. You know, the Cialis or tadalafil is not as affected by meals. It does stay in the system longer. So, and there is also a daily dosage for that. These medications tend to work well. Most guys tolerate it well. You may get a little bit of a headache, maybe a little reflux, maybe some back or muscle pains, but it tends to work well. It usually doesn't interact with a whole lot of other medications. If you ever need like nitrates for your heart, it's kind of a contraindication to ever be on these medications. But for most part, you can take it with other, medications you may be on. You may have tried some of these. So, sometimes it's just not taking it correctly or with food or not early enough. Another thing we find a lot is that, they may have been really expensive to get these in the past. Currently, they're all generic now. So we have access either using like a good RX card or we both use some compounding pharmacies. We can get these medications for very cheap. So if you find you're paying a lot of money for these, please reach out and we can figure out ways to get it to you more affordably. So once those medications stop working, we kind of start to talk about some of the more advanced options. So intracavernosal injections is just a fancy way of an injection into your penis. So it's a self-medication, you inject directly into the erectile body. So here in this diagram on the bottom, there's kind of 3 tubes within the penis. There's 2 erectile bodies and then one that where the urethra or urine comes out of. So you inject the medication directly into the erectile bodies. Before we have you do this, we do teach you in the office. We show you how to do it safely. These medications tend to work well. They're rapid, about 5 to 20 minutes. It's a slightly different pathway than the oral medications. But there are some downsides to this. Number one, you got to inject your penis every time you want to have an erection. A lot of these you got to keep in the refrigerator. So you got to kind of get up, run to the fridge, come back. The pain from the injection is usually pretty small. It's kind of like a bee sting. But with the medication, sometimes the medication itself can cause some pain. It can cause some scar tissue. There is a risk of the priapism or the erection lasting longer than 4 hours. And that can be is a medical emergency and requires intervention. We find it works well for a lot of guys. I see that most guys don't do this long-term for the variety of reasons I just discussed, but it definitely is an option for you. Sometimes when we're starting this, we'll have you come, both Dr. Thermavalavan and I do what's called a penile Doppler, where we can inject this medication into the penis and we see how it responds in the office. We look at the blood flow. We can assess some kind of the vascular parameters of the erectile process and see if this would be a good option for you, help you titrate the correct dose. So lastly, I'll talk about the penile implant. So this is a outpatient surgery where we put in a device where it's all self-contained, it's all under the skin, no one would know you have it. And there's kind of 2 main types. There's kind of the one that's always rigid and it's malleable, it's bendable, or the inflatable penile implant. The inflatable is a 3-piece device. There's a pump that's in the scrotum. There's a reservoir that goes back underneath the abdomen. And then there's cylinders. There's 2 cylinders in those erectile bodies. And you pump this up, fluid will go from the reservoir into the cylinders and give you a natural appearing erection. It's very firm, it'll last as long as you would like. And then there's a deflate button and you deflate that when you're done. Sensation, ejaculation, all that is what you would have prior to the implant. Patient partner satisfaction is some of the highest of anything we do perform. There are risks. It is surgery. So there's some risks of pain, bleeding. The one we worry about as prosthetic surgeons the most is infection. Luckily, the infection rates are very low. But if it does become infected, we have to remove it and do things there. You can never go back to a natural erection, but I don't find that that's an issue because most of these guys didn't have good natural erections before. This is a procedure where you want to go to someone who's done a lot, is trained well. Both Dr. Thermavalavan and I do a lot of these. We're well trained. We've had very good success. So there are very good options that are out there for you. No guy needs to suffer with erectile dysfunction. And really just invite you guys to please ask some questions. Come in, submit stuff. We'd be happy to see you. And I think we're going to shift over to testosterone here with Dr. T.
All right, thank you very much, Dr. Loeb. That was fantastic. Give me 1 second here while I share my slides. All right, thank you again, Dr. Loeb. That was fantastic. I want to thank Mark White and Tyler for setting this up and allowing us to speak to all of you and to all of you for joining us today for this. So I'm going to talk a little bit about testosterone. Both Dr. Loeb and I diagnose people with low testosterone and treat people with low testosterone. So let's start with the basics. What is testosterone? It's, you see a lot of commercials for it, but when you break it down, it really is the male sex hormone, right? It's the one hormone that's responsible for a lot of your male characteristics, if you will. The hormone that's made in your testicles, and it's important for male sexual development, like puberty, as well as functions like erections, most importantly. So what do we say is, quote, low testosterone? And there is some disagreement on this. Some people would say at any level with symptoms, but the guidelines say that if you have multiple levels below 300 in the morning when you're fasting and you have symptoms, and we'll talk about those symptoms, then you should consider treatment for low testosterone. This is incredibly common, and it gets even more common as you get older. Some of the symptoms of low testosterone include a low sex drive, fatigue. So if you're feeling tired all the time, this is something to think about. If you feel like over the last few years you've lost a lot of muscle mass and put on some fat mass, this is something that could be causing it, or at least partially responsible for it. You can also have some other symptoms like irritability. Erectile dysfunction is a symptom of low testosterone as well. And lastly, depression is a symptom. I just also want to reiterate, if you guys have questions, please send them through as we're going along through that Q&A box. We're happy to answer them all at the end of the session here. So what causes low testosterone? There is a myth that as you get older, your testosterone gets lower, your sex drive gets lower, and that's just it. It's just a part of aging. So that's not necessarily true. We know that men, as they get older, if you're perfectly healthy, which of course is very, very rare and difficult to do, your testosterone does not get as low. So we know if you have certain medical conditions, you have a higher risk of having low testosterone. For example, if you have diabetes, you have about a quarter chance of having low testosterone. If you're overweight, it's almost a third. If you use opioids, or if you're on chronic pain medicine, that lowers your testosterone as well. Certain congenital conditions that you were born with can cause low testosterone. If you had any sort of loss or harm to the testicles, so a history of some sort of accident where you had to have a testicle removed, or cancer where you had to have a testicle removed. Another thing we discovered is that if you work night shift or work shifts where you go from days and nights, that messes with your circadian rhythm and your hormones, because testosterone does not stay the same throughout the day. It goes up and down over the course of a day. If you work night shifts or have sort of an odd sleep cycle, that can affect your testosterone. And a lot of those guys have low testosterone. Another common condition is kidney disease or kidney failure. We see as your kidney failure gets worse or your kidney function gets worse, your testosterone gets lower as well. So why treat it? If this happens, what's the point of actually treating low testosterone? So the main thing is that you get symptomatic improvement. Your energy gets better, your libido and sex drive gets better. It can improve your depression symptoms, and it can improve your erections. Now, a caveat to that is your erections only improve if your testosterone was very, very low, and then we get it to normal. If it's sort of borderline low, it doesn't completely change your erections. You have to really sort of also look into the options that Dr. Loeb just described. What solutions do we have to treat low testosterone? Like with most things in medicine, diet and exercise is a great place to start. It's probably not going to make a huge difference, and to be honest, most guys end up going with testosterone therapy because that actually allows you to kickstart your diet and exercise at the same time. But it certainly will help your overall health. It may improve your testosterone a little bit. Now, testosterone therapy comes in many forms. Skin gels that you rub on yourself, and we'll talk more about all of these. Injections that you can do at home or in the office. Nasal gels that you put in 2 or 3 times a day in your nose, pellets that go underneath the skin, or now, most recently, the FDA has approved some pills for low testosterone. So let's talk about the gels. You apply these to your skin daily, usually in your armpits, your shoulder, or your thigh. Overall, it gives you a pretty steady level of testosterone. It doesn't get super high like that. And you don't get too much variability in your levels. There's one side effect that you have to be careful of, and I tell this especially to guys who've got sort of young kids around, is that it can be transferred. So you got to wash your hands very, very carefully after you're done. You've got sort of, you're rubbing on your shoulders and you got little kids climbing on you and stuff, you got to be careful with it. Injectable testosterone is probably the most common testosterone that I prescribe or my patients pick. It's an intramuscular injection, meaning it gets injected into the muscle, usually the muscle of the thigh. I usually start men off at about once a week. And then we also have another option, which is an in-office injection called Avid. And the first 2 injections are 4 weeks apart. And so it's a more long-acting testosterone. And after that, you inject yourself we inject you every 10 weeks. Intranasal testosterone probably been around about 5 years now. It's one of the newer testosterone. It's a nasal gel, so it's kind of like a Flonase, but more of a gel than a spray. You put it in your nose for 2 to 3 times a day, and then you kind of let it sit there for about an hour. You can't blow your nose for an hour afterwards as it gets absorbed. The nice thing about it is that it is short acting, so you maybe have fewer side effects, so that's still sort of being investigated. But one of the side effects you do get is sort of a nasal stuffy feeling. So if you've got sinus issues, then people stay away from this. And then testosterone pellets. Both Dr. Loeb and I do what's called the Tesla pellet procedure. This is an in-office procedure where we put these pellets, and you can see them on the screen here, underneath the skin of sort of your hip. They slowly dissolve over about 3 to 6 months. And then you repeat the procedure in 3 to 6 months. This works well because it's very low maintenance for you at home. You don't have to do anything. And it gets you a decent level of testosterone. The only downside is if you want to adjust the dose because you feel like it's too low or too high, you have to wait till the pellets fully dissolve. And then on the next time you have the procedure, we change the amount of pellets that we put in. So this oral testosterone is actually the newest form of testosterone. I haven't used it much yet because it only got FDA approved, I believe, a little less than a year ago or something around there. It's an oral testosterone. You take it twice a day with food. Like with any medical therapy, there are risks, right? So all testosterone therapy carries these risks, some more than others, but they're all manageable risks that we sort of watch you for. So the most common ones are you see increased blood counts, blood pressure, and cholesterol. Usually not severely so, but it's something we keep a track on every few months when you come in. The one thing that happens very commonly is that when you take testosterone, your body says, hey, all this testosterone, your mind says, hey, why do your testicles need to keep working? So basically, your testicles will get smaller, and they'll stop making their own testosterone, and they'll stop making sperm. It's not dangerous in any way unless you're trying to have kids. So if you think you may want more kids, we actually would recommend that you bank sperm or save sperm beforehand. Your sperm production can come back if we stop your testosterone later on, but it's just something you need to be aware of. Now, most of the guys I see are beyond the point of having more kids, but it's just something you need to be aware of. You know, there is a concern about possible cardiovascular, meaning heart attacks and strokes with testosterone. That being said, the evidence is still sort of controversial. There are a few trials that show maybe there is an increased risk, but there's also some that say there's an improved risk. So we don't know the actual answer yet as to whether this has any real effect on your heart in a bad way. It can improve your erections, like we talked about. You can get some acne sometimes and swelling in your legs and some fluid retention, more so with the injectable testosterone, not the other kinds. Because of these side effects, it's incredibly important that you see us regularly once you start testosterone. And we actually see you every 3 to 6 months to check your blood work, make sure the testosterone is in the right level. Sometimes your estrogen levels can go up, and we'll give you an estrogen blocker as well. So the important thing to remember is that this requires continuous follow-up. And we try you for about 3 to 6 months to see whether you improve. If you don't, then we stop the testosterone. And most patients do improve or notice the improvement in that first 3 to 6 months, but the recommendation is to try it for about 6 and then decide whether or not you want to continue it. So to wrap up some of the presentation portion of this, the take-home messages: erectile dysfunction, testosterone are very, very common. I hope we've impressed the importance of that to you, as well as the reasons that have been evaluated. There are many solutions that kind of fit your individual needs and how much you want to pursue each of these things, and the ones that and solutions that will fit your specific lifestyle. And lastly, please don't suffer in silence. We know as men in general, we're not big about going to the doctor and talking about a lot, but some of them are very important, not just for specifically your erections, like Dr. Loeb mentioned, but more for your overall health, like your heart and your overall general well-being. With that, thank you guys for joining us, and we're both happy to take any questions at this time.
Thank you, doctors. We'll start off with our question and answers. Again, for all the attendees, at the bottom of your screen, you'll see the Q&A function. This is where you can submit the questions for Dr. Loeb and Dr. Thermavalavan. You can also click a anonymous button when you submit your question if you choose not to have your name posted. Our first question is, do penile implants increase flaccid and erect penis size?
Yeah, so that's a very common question. It's a good question to ask. So actually, I have a sample of one here. So, we fit the penis to, what the stretched penile length is. So the device never changes in terms of length. When you inflate it, the fluid fills here and you get girth enhancement and rigidity. So the penis will go from kind of flaccid to erect. So it probably would increase your flaccid length. It's not going to really increase your erect length. And that's one of the things we talk about in the office. And I always show guys, I hold the penis out on stretch and I say, this is what the length of your penis is going to be with the penile implant fully inflated. It may not be what you were back when you were 20. A lot of that is you've added a little weight. Some of the penis may be kind of buried underneath the skin. Or you can lose some penile length from years of not having good erections and not getting nighttime erections. It's kind of a use it or lose it a little bit. It can get kind of scarred down. So we can't really increase length with the penile implant, but definitely increases girth and rigidity.
Okay, our next question is there anything trans women can do to reach and maintain erections, granted their testosterone is purposely lowered?
That's a great question. I mean, I think a lot of the options that we use, in cis men, the pills, injections, and even implants are all an option. I'm not sure. I think this would be a great area from. I don't know if Dr. Thermavalavan.
I didn't hear the full question. Was that? Could you repeat it again?
So, sorry.
Go ahead.
Yeah, anything in trans women can do to reach and maintain erections, granted their testosterone is purposely lowered.
Yeah, I mean, so that's a great question. We know that in trans patients who are taking estrogen, your erections will get worse with the estrogen. However, even men need a little bit of estrogen to have good erections. So Cialis still will work and preserve both erections and erectile length to some degree. And so when we have, I actually saw this patient the other day who is starting hormone therapy with estrogen. So we're starting Cialis at the same time at a low dose to try and preserve those erections.
Okay. Our next question is, between testosterone, free serum, and total testosterone, is there a difference on the test results and what do they show?
Yeah, so that's a great question. Total testosterone is essentially total testosterone that's in your bloodstream. A good amount of your testosterone is bound tightly other proteins. And so the free testosterone is a testosterone that's not stuck to other proteins and that can actually activate. So if either one of those is low, we would consider you for testosterone therapy. With total testosterone, depending on what guideline you use, either a level below 300 or 350 would make you a candidate for treatment. With free testosterone, it's a little bit more vague as to what level we actually cut off, if you will. There's many things that could make your total testosterone normal, such as liver disease, but your free testosterone be abnormal. So that's why we use both lab values when screening for low testosterone.
Our next question is, do you know if testosterone pills have been approved for trans men?
That is a great question. I do not believe so, but I'm not 100% sure because they're relatively new. I'm not 100% sure on that.
Yeah, I find that a lot of the testosterone, it's very dependent upon your own insurance provider. So even beyond the reason you're taking it, sometimes we have to negotiate with insurances and do prior auths. You kind of have to go through, the injections, the gels, the pellets. So it's something worth looking into, talking with your own insurance provider and seeing. And a lot of times our offices can help with that as well.
Even if it's not, I second that. It's certainly hard to get it approved sometimes, and some insurance companies will use a cutoff that has, approved. Like I remember one insurance company said they wanted a level below 200, whereas none of the sort of guidelines, none of the evidence say that that's the right number to use. But even if it's not covered, Dr. Loeb and I work with compounding pharmacies that can get you testosterone to be sort of an out-of-pocket payment, but it'd be cheaper than if you went to like a CVS or something like that. So there are solutions that are sort of at least reasonable cost-wise if your insurance won't pay for it.
Our next question, the person says they've never had sexual intercourse with a person, but exposed to other types of sexual activities. They're about to get married and are worried that I will be able to perform. What can help me in that regards?
I mean, I think a lot of it is just, it's a lot of, psychological coaching and letting you know that things will be okay. If you've been getting erections, for masturbation or other types of sexual activity, just being comfortable with your own body and your partner and just trying to be kind of intimate. And like I said before, not thinking about your own penis and your own performance. And that can be a hard thing to do. Sometimes even, trying one of the pills, the Viagra, Cialis, I have a lot of young guys or, patients who have, pretty good erectile function on it, just to kind of help them get that extra confidence. You're not going to become addicted to these medications. You're not going to become dependent upon them. But if you're worried and you think that may give you a little bit of a boost or maybe a little bit of confidence and kind of frees up your mind a little bit, I think it's safe to do.
Yeah, other thing I would agree with that, and I'll also add, talk to your partner very openly. Let them know that. I think that will take a lot of the pressure off.
The next question is, does erectile dysfunction or testosterone intervention increase the risk of STD or STI?
No, I say neither of those does. I mean, no matter what your treatment is for erectile dysfunction, you should still be practicing sort of safe sex, use contraception and or protection, depending on your partner and things like that. But neither of those increase your risk for sexually transmitted infections, no.
The next question is, would like to know, what about the use of testosterone with the decompensated liver function?
That's a good question. Historically, maybe 2 decades ago, there were oral testosterone pills that affected your liver. And so that's why oral testosterone went off the market. However, now even in patients with significant organ dysfunction, like dysfunction, testosterone is considered safe. Obviously, if we would run it by your liver doctors and make sure they didn't have a specific concern regarding it, but it is still considered safe. We even use it sort of in transplant patients, liver transplant patients is considered safe.
The next question is, what is a good starting dosage for sildenafil?
Yeah, so a lot of times they come either in 20, 50, or 100 milligram tablets. So 20 is kind of the lowest that I'll ever start guys on. And we can kind of titrate it up to 100. Usually going beyond 100, I don't see a whole lot of increased clinical efficacy or improved erections. Usually you just get a bigger headache. But I tend to start guys at 20 if they want to start low. But if you want to push it to 50, 100, it's in and out of the system relatively quickly. And so, but it's always easier to start low and kind of increase up. I don't know if Dr. T has a different
I would agree with that. I think that The biggest side effect we worry about, obviously, is a prolonged erection. That's the one you've all heard about in the commercials. You get an erection for 4 hours, you call somebody, right? But in reality, I mean, I think Viagra and Cialis, or the generic forms, are probably the most common things Dr. Loeb and I prescribe. And I don't think I've seen a single prolonged erection in the emergency room because of the pills. So it is a listed side effect, but it's incredibly rare.
Our next question is, my PCP prescribes injectable testosterone, but he won't even talk about or even test estrogen levels. Should I be looking for another physician?
So I don't want to go out and say you need to be looking for another physician. I'm not going to say that, but I will tell you in our practice, what can happen when you take testosterone is that there's an enzyme in your body called aromatase. So the more testosterone you take, some of it does get converted to estrogen. That's a natural part of your body. So it is a good practice to check estrogen every once in a while and give you possibly a medicine called anastrozole, which will block that conversion, because you don't want your estrogen levels to get too high. If they get too high, you can get breast enlargement, tenderness, pain, you can get like nipple sensitivity. So what I will do sometimes, if I know I'm starting somebody on injectable testosterone, I will actually start the estrogen blocker at the same time, because I almost know you're gonna have a high estrogen in 3 months, so we might as well get ahead of it. But that's not sort of a common practice. It certainly is only done by people who are very sort of specialized in testosterone treatment.
And our next question is it safe to use testosterone and or get an implant if you have HIV?
I would say yes to both.
Yeah.
The next question is beginning to point of kidneys started forming kidney stones. What is or is there a link to testosterone?
Sorry, I didn't understand that question. Could you repeat that?
I believe the person saying that they're starting to form kidney stones and wanted to know if there's a link to kidney stones and testosterone.
Not as far as I know. I don't believe I've ever read anything that shows that there's a link between kidney stones and testosterone. Now, I will say that if you are seeing a urologist for kidney stones or seeing a urologist for testosterone, you're more likely to get diagnosed with the other, right? Because you're already seeing somebody who specializes in that. I don't think there's any scientific basis for those two things to be linked.
That appears to be, here's one more question. What are some pros and cons to Viagra versus Cialis?
Sure. So in terms of, I think they're both very good medications. The Viagra is kind of a shorter acting medication, and it's often kind of a starting point. The Cialis does last in the system longer. There's also a daily and a as needed dosing for the Cialis. So for a lot of people, it's just easier to take a pill every day and not worry about the timing. And the Cialis also kind of the as needed dosage. Sometimes you can take it on a Friday and it'll kind of stay in the system through the weekend. They're both very affordable now, so they cost about the same. We can get these for less than $1 a pill. So I don't think it used to be a big cost difference. And the side effect wise, with the Cialis, sometimes you can get a little more of a back pain, a little ache there. The Viagra, I see the guys tend to get a little bit more of a headache. And so you can kind of switch and kind of play and find which one works best for you. And depending upon those things and your lifestyle and all that, I think they're both very good medications.
Still have a couple minutes if anyone else has questions for our physicians. Dr. Loeb or Dr. Thurmavalan, any other common questions you get asked during your practice that you'd like to address?
So I'd say one of the common things I see, especially now, is that there's a lot of guys who are taking these like testosterone booster, erection boosters by like Amazon, GNC, and I would just be very careful with those. A lot of those got pulled off the market by the FDA because they were just sneaking in Viagra, and so they may have had some effect, but it was because they were sneaking in Viagra. The other thing to note, we actually have done some work looking at all the ingredients and all these. They don't have a lot of great evidence that they work, and because they're supplements, they can say whatever they want, and they don't really get evaluated systematically. So just be very careful with taking those. Just definitely don't waste your money on a lot of those. I don't think they do that much for you.
And one more question. What do drugs like Viagra actually do to increase blood flow and facilitate erections?
I mean, so in the simple way, they vasodilate. And so to get a good erection, you need dilation. So blood flows into the penis and then it kind of traps it in there. I mean, these medications were initially designed for kind of some cardiac and pulmonary issues, and they found that they didn't work great there, but the patients were getting great erections, and it changed Pfizer forever. And that's what they do. So that's why sometimes you get that headache, you get that dilation, you get blood rushing to the head, or you get that reflux, kind of that heartburn, because things kind of dilate there. Looks like L-arginine. L-arginine is kind of in the same class. It's not as studied and regulated as the phosphodiesterase inhibitors, but L-arginine is similar. A lot of like pre-workout stuff like that is kind of the same thing. It kind of vasodilates things, and it comes in a lot of the supplements that Dr. Thermovalvon just mentioned. So you'll see that in the label for a lot of those.
Our next question is, can my BP go too low with those meds? Also, I assume I should avoid poppers.
So one of the side effects is that it can lower your blood pressure. Usually in patients who aren't taking nitroglycerin or anything like that, it's not severe. So it doesn't become an issue. But if you take any sort of nitrates or nitroglycerin for chest pain, it's sort of contraindicated. You can't take Viagra. So for example, if you even have it on your med list, even if you haven't taken it in a while, I usually don't prescribe it to people. The good thing is if you're not able to take the Viagra for those reasons, or Cialis, or any of those meds, penile injections and sort of a good solution that you could use.
Now, doctors, maybe something you could help describe is currently with the era of COVID here, how we're keeping people safe in terms of whether they want to come into the office or also through virtual appointments.
Yeah, I mean, I think we're all concerned about that. I mean, Nana and I both have young kids and families, and so we want to be comfortable here at work. And we're doing a lot of different things to make sure our office, our staff, ourselves, our patients are safe. So we're available for virtual visits, so telemedicine. We can connect that way. We are having patients come into the office, and we're doing things like touchless check-in, where you can check in from your car and come straight to the exam room. We're wearing masks. We're washing our hand. All the things to make sure that kind of limit the contact as much as possible. And we're doing the same things. We're doing surgeries in the hospitals, and so I feel very comfortable coming to work, going to the hospital, doing cases. We want our patients to feel comfortable as well. And even if you're not comfortable coming in, virtual visits are a great option right now.
Yeah, I second that. I think our clinic is taking a lot of caution, people say, for patients and staff, right? So obviously all masked up, we're gonna ask you guys to wear a mask as well. And if you're feeling sick, stay home, if you're not feeling well, stay home, and we can always do a telehealth visit or just reschedule for later on. Those are also great options.
And people certainly should not be delaying care, right? If they're having an issue, they should be sure to come in.
Correct.
Right.
Well, I believe that looks like it's going to wrap up our Q&A for today. Again, just a reminder to all the attendees you will be receiving an email in the coming days with a link to this. You can go back and watch this and share it with friends and family. And you'll also have additional contact information to Dr. Loeb and Dr. Thermovalvon. But we encourage you to call the number on your screen and make an appointment with them as well. Any closing comments, Dr. Thermovalvon or Dr. Loeb?
Thank you all for joining us. Please don't hesitate to come see us, and we can sort of talk more in detail about anything that concerns you.
Yeah, thank you so much, and have a good night.
Thank you, everyone.
Thank you.